I'm going to talk about elbow arthroscopy, teach me how to do it. I think starting with positioning, the challenge for me when I was doing elbow arthroscopy or starting to do it was the space between the elbow and the patient's torso. So when I'm going through the different positions, keep that in mind because that's what's going to really help determine which position works best. So the supine position was described by Andrews. It has a lot of advantages. It's easier for the anesthesiologist. We're all used to operating in that position. You're easily more anatomically oriented, especially in the anterior compartment, and it's easy to convert to an open procedure if you need to. There are several disadvantages that I found when I was doing this. You need a traction device, and it was difficult to work in the posterior compartment. You're working up into the posterior compartment, which is very non-ergonomic. You want to work down towards the posterior compartment. And the shoulder naturally wants to go to about 45 degrees of abduction. So even though with a traction device I would get it to 90, it would just invariably would come to 45, and I just got very frustrated with it and abandoned it. So lateral decubitus was described by O'Driscoll and Maury. Advantages are, again, it's easy for anesthesia. You're working down into the posterior compartment, but the disadvantage is you have less distance between the elbow and the patient's torso, so it limits your scope. And therefore, I've switched completely to prone for many years now. The advantage is it sets up just like a knee. You're working down into the posterior compartment. You don't need a traction device, and it also gives you the largest distance between the torso and the patient's body. It's tougher for anesthesia. They've all gotten used to it. They don't complain anymore. It's not a big deal to do it in that position. So this is what I mean by, even though I've maximized the space between the elbow and the torso, I'm getting very close to the patient's body, but that gives me a lot of space. And again, I can easily convert to an open approach. I put a padded Mayo, work on the lateral side of the elbow. I can do OCD of the capitellum in this position. And also on the medial side, I've done Tommy John surgery in this position, ulnar nerve transpositions in this position in a prone, so you don't have to re-prep and drape. Tourniquet, you absolutely have to. There's no issue there. It improves visualization, decreases bleeding, and allows you to have a lesser pump pressure. This is very simple, but when I figured this out over the years, it changed my elbow arthroscopy, believe it or not. But having the anesthesiologist pull the drape and clip it so it's under tension prevented the drape kind of falling back onto the field, and I was constantly having to struggle. It doesn't happen with knee scopes. We don't have to worry about it in shoulder scopes, but for elbow scopes, it definitely happens. So putting the arm in the bag so the fluid gets collected into the bag. I always draw out my anatomy. I always write out the nerve because it's in the prone position. I don't want to get disoriented and make sure that I don't damage the nerve. The pump pressure, I keep it very low, 15 to 20 millimeters of mercury. I use a standard 4 millimeter 30-degree scope, just like in the knee scope or a shoulder scope. I don't use the hand weenie scopes. Use of retractors are very useful when you're first starting out to do elbow arthroscopy. That definitely helped me be able to do more complex cases with the use of retractors. So here's an example of a patient who has arthritis in the anterior compartment. He's got an anterior shelf osteophyte, and I used just a switching stick through the same portal through my anterolateral portal that my burr comes in, so I don't make an accessory portal incision, essentially. So that keeps the brachialis out while I do the osteophyte resection. What also helps is in the for the anterior compartment, if I have my assistant just flex the elbow just a few degrees, it loosens up that anterior capsule and gives me more working space in the anterior compartment. My standard portals are the anteromedial portal, which is 2 finger breaths proximal and 1 finger breath anterior to the medial intermuscular septum. My direct posterior and posterolateral. And then I use this anterolateral portal, which is right in line with the radiocapitellar joint. You can also use a soft spot portal to look at the capitellum better. I don't routinely use that portal, though. These are some accessory portals higher up if you need it to place retractors along. You just have to worry about the radial and PIN nerve up here with this accessory portal. I insufflate the joint with about 30 to 40 cc's of saline, placing it through the soft spot portal, and that pushes the neurovascular structures away, and it also insufflates the joint. So when I pop in with a scope, you'll see that in a second, the saline leaks out, so I know I'm in the right place. I start with the anteromedial portal, and I just use the tip of the 11 blade. I just want to go through the dermis so I don't damage the medial antebrachial cutaneous nerve. I don't want to be known as a butcher of that nerve too, Rob. So I'm very careful with that. And then to get into the anterior compartment, I hit the medial side of my humerus, and I feel the posterior and anterior surfaces. So I want to make sure I'm on the anterior surface, and then I I just glide on the anterior surface of the humerus and pop into the compartment. So you'll see here that I'm feeling the cortices, that's the anterior surface of the humerus, and then I raise my hand about 45, 50 degrees and advance, and you'll see the valve is open. So as soon as I pop into the joint, the saline comes outside. That confirms that I've placed it intra-articularly. So in looking at the anterior compartment, I think it's important to pronate and supinate. You can see here with pronation, you can really see the anterior face of the radial head. You can see the annular ligament, the capitellum. Oh, I'm sorry, I need to go back one. So as far as orientation, when you're in the anterior compartment, I rotate the camera as if I'm looking at a lateral X-ray of the radiograph. So this is humerus and the capitellum and radial head. That's the same exact orientation. We're all used to looking at a lateral radiograph of an elbow, so that's why I orient my scope like that, so I'm used to it. So to create, I normally here would just make an incision, put a snap in, and create this anterolateral portal. But if you're just starting out, there's this percutaneous system that's commercially available. You go in with a spinal needle, put a guide wire in, you make a small stab incision, and then you have a 2 millimeter dilator that goes over the guide wire, and then a larger dilator which goes over that, and then eventually you can put a cannula over it, so you can safely and securely enter the anterior compartment from the anterolateral portal. So I start from the anteromedial portal, but I always use a switching stick to go to place my scope through the anterolateral portal, so I can also examine the medial side of the joint in the anterior compartment. So the switching sticks are my good friend here. So this is looking at it from the anterolateral portal. You can see the tip of the coronoid, the annular ligament there. So again, if there's arthritis, you can see osteophytes off the tip of the coronoid. You can see the shelf osteophyte that I showed earlier. So that portal is very safe. This is the brachioradialis right here. Brachialis is right there. The radial nerve is right between that interval. So I'm just demonstrating how far away that portal is from the radial nerve. So I'm not worried about radial nerve injury with that portal. It's about 2 centimeters away from that portal that I come in at. This is a case of a patient who had a snapping elbow. I've seen maybe 3 or 4 of these in my whole career. It's one of the easiest surgeries to do, and the patients are very satisfied. You can see it's hypertrophic, it's unstable, it keeps snapping over the radial head, so I just come in with an 11 blade and excise that accessory ligament. I've seen them 1 post-op visit, and they're done, and they're very happy, and they essentially never come back for a follow-up appointment. So just to speed this up a little bit, you can see that snapping is eliminated. In the posterior compartment, I place my trocar in the posterolateral portal. Whenever you get in there, this is what you see. You just see a lot of fat pad, so you don't get immediate visualization in the posterior compartment. So I put my shaver with the teeth facing laterally so I don't accidentally get the ulnar nerve. And I know I'm in the Olecranon fossa, and I can feel the tip of my scope with the shaver. So making those circular movements with my shaver, I create a space. I open up the space, and you can see the shaver is in the Olecranon fossa, and it's very safe. So as soon as I do that, that gives me visualization in a posterior compartment. There's always this band right here that's part of the triceps tendon. I routinely remove that, and as soon as you excise that, it really opens up the posterior compartment for you. I make sure that I'm working on the lateral side first before the medial side. And then to examine the lateral gutter, I switch my scope through my direct posterior portal, and I lead the way with a shaver because there's always this fatty tissue, synovial tissue, that blocks my view. If I go in there with a scope first, I'm going to have a hard time seeing. So I kind of clear my path with a shaver first, and now I can take my scope out from the direct posterior portal and place it through the posterolateral portal. And here you can pronate and supinate, and you can see the entire surface of the radial head and part of the capitellum. And then at the end, I always throw a freebie. I put a scope in the ankle joint. You'll see the ankle joint right here. You can see the talus, the medial mal, the fibula, the plafond, so it's a free scope we throw in there. The medial gutter, essentially, I routinely check that for loose bodies, and then if they're throwers, you can kind of put a valgus load and see opening of the medial joint space, like you see in this athlete. In patients who have a large olecranon spur, I used to burr this down, but now I excise it with an osteotome. So you want to denude the olecranon osteophyte all the way down to the triceps insertion, which we just saw. And then I come in with a half-inch curved osteotome, and right above the triceps insertion, this is my resident, loves this part of the case. They get to mallet this off, and I take it all out in one chunk. So it's a lot faster, and I'm not creating a ton of bone dust and bone debris. And I don't have to make a large incision to take that out. And I don't have to worry about taking all these posterior shelf osteophytes because I've taken this out. And that usually is the culprit in arthritic elbows. It's not really the capsule, it's the bony problems. So in patients who have loss of flexion, if they have a flexion contracture, I release the posterior medial capsule. This is the only part of the elbow that I don't go with a shaver. I use these baskets. You'll see in a minute, the ulnar nerve is right there, right behind that. So I use the baskets to release that, and there is the ulnar nerve. So it's very close. I'm too scared to use a shaver there. But so, everyone's worried about elbow scopes. Again, we looked at our Kaiser data. We had 560 consecutive elbow scopes. We had a very low complication rate. So don't be scared to do it. Start with easy cases and then work yourself up to some of the more complex ones. All right, thanks.